Social isolation is one of the key conversations which always come up, and then if there is any program being talked about.
So social isolation is one thing, but also I think loneliness is another.
The conversation on mental health, because everybody having that touch base with people of different age groups and demographics.
It looks really different because people are craving that interaction. Having the skills to actually respond to that doesn't come naturally to everyone. We have our younger people coming through who are very happy to, use social media, or not social media, what do you call it? Look at me. Electronic devices.
The games,
some of the digitalisation will be challenging, but also has those opportunities as well.
Welcome, Monica. How are you?
I'm very well today, thank you.
First of all, thanks for your time, and thanks for agreeing to be involved at our upcoming conference. So glad to have a voice like yours to be on the panel and having that important conversation.
Yep.
I want to get to know more about yourself and your department, and please share a bit more about yourself and what you've been doing.
Mm-hmm. So my role is Deputy Commissioner at the WA Mental Health Commission. So the WA Mental Health Commission actually differs a little bit from other commissions throughout Australia, because we actually have the remit around delivering the mental health, alcohol and other drug services for the state, whereas that remit is actually sits with other areas in other states. So we're quite unique in that, and which makes it actually critically important that we have a good understanding around what the sector needs are, but that we're also really responsive to what's actually occurring, not only in our own Department of Mental Health, but also understanding what the other government departments and sectors are actually experiencing as well, in order to respond adequately. So it's been an amazing time for me to come into the Commission. We're just at a point by which our last strategy is nearing completion, so our last 10-year strategy, and so we're in the development of our new 5-year strategy, which will come out for further consultation shortly. So it's a really quite an amazing time to be involved with mental health and alcohol and other drugs. And what we're seeing now is from our last consultation that we're actually hearing that some of the things that have been done already have actually really already made an impact as well. So it's been really, really positive to talk to communities who are actually saying it's not everything that is a gap now, but there is sort of absolutely some room for other things to be progressed more than they have been to date as well. So clearly with the last election, we now have 2 ministers as well. So a change in what was the Minister for Mental Health. Now we have an additional minister, which is the Minister for Prevention. So which has been really highlighting what the importance is of ensuring that we're having a preventative approach versus actually just looking at services that are down the track for mental health and AOD. So it's been a really big change for us, but a really positive change, which will actually see us clearly have a more focus around prevention going forward as well.
Can I take a step back in terms of your career trajectory as well?
Yeah. Sure.
In terms before being Deputy Commissioner, if you can give us a bit more understanding of how has your career evolved to be leaning towards mental health and championing that cause. But how has your career evolved across the last couple of decades?
Yeah, sure. And you're very generous to say a couple of decades. I must look quite young today, but it's been a few more than a couple. I grew up in the country and was really attracted to something that took me away from the country, and started a hospital-based mental health nursing career. So moved away from the country into the city, and and have been a mental health nurse for over 30 years. So a really long time. And with that, I guess I've been really quite committed to mental health for many, many years from a nursing perspective, but I've always had a particular interest in improving governance of mental health services so that people actually not only get services, but they actually get really good, positive services that lead to good outcomes. So I've had an interest over my career around safety and quality, good outcomes, and also financial modelling so that it's really cost effective for both the individual to actually receive care, but also I've spent most of my time in public mental health services. So, and as I say, I had a particular interest in safety and quality. So really have stayed quite consistent around my experience in nursing. Moved into management about 10, 15 years ago at an executive level, and became a bit more involved in obviously funding models and then became involved in assessing services as well from a safety and quality perspective. So, which has really, I guess, burned my interest to where people become quite innovative in the things that they do to actually get better outcomes for people as well. So, and often it's with very little resources, and sometimes it's as a result of not great things happening. So, so I've always sort of felt like I've had a balance around quality improvement and ensuring that services can continue to do the best that they can possibly do for the needs of who they're serving. So,
and can you give us a bit of a lay of the land? How has the mental health, understanding of the mental health as a separate sector, or the need of talking about mental health at different levels of within the public service as well as within the community overall, how has that evolved in the last 3 decades of your observation and of your work?
So really significantly, I think no longer is their naivety around mental health and mental illness. Like people now, and I have the great privilege of being a mum to a early adult, and they talk so openly about mental health now, which is absolutely fantastic. However, with that comes some challenges of how to respond to people who are not necessarily looking for what was 10, 15, 20 years ago around purely about diagnosis and medication. People are now actually looking for things that actually suit their lifestyle, suit their affiliations with their community as well. So I think now we have some challenge around the traditional way that services have been delivered and being really responsive to how we might do that differently for different age ranges. With that also comes the challenge around don't assume too much that someone who's a bit older, is not as digitally able as a younger person. So again, actually really understanding what your community needs to be able to develop services with them instead of actually just to them. So I think just the awareness and conversation around mental health and is incredibly positive compared to what it was a number of years ago. What is also significantly different is no longer do people actually want to go to services just for one thing. They will share their life and issues with lots of people. So it's very hard from a workforce perspective who potentially 10, 15, 20 years ago cared for a person in isolation to all of their other concerns in their life. There's an expectation now that people are actually really responding to other things that are interfering or intersecting with someone's life that's causing them concern. So again, really that challenges how people seek services, but also how services need to look as well. So you'll see now there's one-stop shops and hubs where there's actually services of multiple sort of
care providers
capability, and that is really addressing what the community is actually looking for now. So.
And from a point of view of mental health services portfolio in the state, how do we define the breadth of services one typically access? And if you can just again paint a picture in terms of the kind of services people would be accessing from different support. They might not be going to a public service center. They might go to a third-party organization who are delivering those care services or specialized services. If you can explain a bit more in the expanse of the service portfolio.
Sure. I think an example that would be good to use is one around students that are living in accommodation to go to university or another sort of training facility, and congregating people together, young people together. They come with different issues, different levels of distress around their education performance, but also different issues to do with being displaced from maybe their family. And so what we're doing is actually really supporting them with supports in that accommodation sort of environment so that they can actually continue to thrive, continue to learn, but actually with different levels of support. So that's a great example of actually how we work with other departments to ensure that people are getting good care. Another example is fly in, fly out workers, so who again are away from a lot of their supports. So the Commission's actually been working with other departments around how we can support them and give resources to both their managers and also themselves to actually be able to thrive in their work environment as well. So that's a couple of examples around how services are actually changing, that no longer is you're having to go away from what is your usual environment to gain services, but services being inserted in what is your your environment by which you're living or learning or working. So
mental health is also mostly a state subject, but their federal strategy on national mental health, on mental health federally as well. So how does what kind of bilateral arrangements state and federal has, and then how do you define who does what in the whole mental health conversation?
So many bilateral arrangements, as you can well imagine. So so lots of conversations. So lots of involvement with primary health networks, which are sort of federally driven, but also keeping awareness of actually how what is Commonwealth funding versus state funding, and again, if you keep the person at the heart of actually what you're doing, you actually try and work these things out as well, and I guess ensure that your representatives at all levels have an awareness of what the state challenges are versus the federal policy direction as well. So there's some really clearly quite enormous changes that are afoot at the moment around the NDIS structure. So for us, we ensure that we actually have our lived experience representatives letting us know what the challenges are around that, but also what the opportunities are as well. So, and then we of course have the ability to be able to feed those items up across to be able to have our state really representative on a national level. So.
And Western Australia is a large state. Western
Australia is a very large state. So.
And because the remoteness is fairly remoteness of WA, and how has not just the commission, but how has the delivery of services across the regions, and what kind of challenges you are facing in terms of workforce, the delivery of care, and an understanding that service delivery model has to evolve, understanding the geography of the distance.
And I think expectations as well. So, of course, everyone would love to have, services delivered to them, where they're seeking them. Sometimes that's not always possible, but we do try and actually understand from the community where their demands are, what's actually maybe limiting them being able to receive care remotely, for example, but giving people options. So there's lots of options available around e-chat and also phone, video, and in person. So actually understanding that for some people they will have the capacity and capability to be able to get to alternate places, but also we're absolutely recognising with mental health and alcohol and other drugs is some people do not want to necessarily receive care in their direct community because it's not the healthiest thing for them. And so we're understanding that that's not for everyone as well. So I guess in answer to your question, really giving a breadth of options for people, but also listening as to what might change, and also the reality of what is available workforce as well. Sometimes that is to do with upskilling practitioners that are within the local community. So we do have a training arm as well through the Mental Health Commission that we provide training around mental health and alcohol and other drugs, and also social and emotional wellbeing for our Aboriginal communities as well, in order for them to have a little bit more capability in addressing what might be an immediate concern at the time. It's really complex. Not one easy solution to the tyranny of distance.
The tyranny of distance, yes. That's what the word I was looking for initially. The geography of distance, I said.
I know, but it's what a phenomenal state it is. So, and I think many things sometimes seem to be concentrated in particular areas. So, and again, that suits some people as well. So, and sometimes we find that, just the nature of many people actually looking for services, you actually have to have a real plethora of services available versus just one type of service. So,
what kind of observations or insights are there from a mental health point of view of West Australians coming up on your desk that there are trends of specific kind, and what kind of actions the department is working on? Yeah,
I mean, I think people are challenged with access, and I think also that people actually understanding and being able to navigate the system as well. So because it is very challenging to understand sometimes what your I think my needs are this, but sometimes the services are telling you your needs are something else as well. So navigation is an issue that has been raised to us on a number of occasions, and we've recently developed our community treatment support and emergency response agenda, which actually is going to assist us to amalgamate and also enhance particularly access, but also understanding when people might need treatment versus levels of support, and then how they might also transition out to other parts of services like your general practitioner, and how specialist services might work together so that people get good care. Because not everyone needs to be within a specialty area forever.
Yes.
But they might touch up against the specialty area multiple times in their life as well. So, understanding that when people need care, where they need care at critical times. So that's quite a clear strategy that we're working on at present around navigation and also crisis support. So we've got two quite key programs at the moment around ambulance and police co-response. So recognising that people, 000 is a familiar number, really hard to remember all of the other numbers. And so we're trying to obviously ensure that if people don't need that emergency response, that if it's a mental health intervention, we're able to intervene so that they can get the levels of support they need. So, yeah.
From a point of view of elderly West Australians, social isolation is one of the key conversations which always come up in these conversations. I don't know whether it's a federal or a state-based conversation to be had, but what's your view on that? And then if there is any program being talked about?
Yeah, so social isolation is one thing, but also I think loneliness is another. So, because you can absolutely be in amongst a mass of people and feel terribly lonely as well. So I guess that's some of the what is the support services that we're got in place already, but also exploring a little bit broadly what we might need. It's absolutely not a older person only matter now. It is a national agenda around social isolation and loneliness. So, but we know it's absolutely a really tricky issue to actually say, well, there's one solution to that. So because that might mean for one person it means something, and for someone else that actually means something completely different. So social isolation and loneliness is a conversation we are aware of, and multiple government organisations are talking about that collectively, and also in line with suicide prevention, of course, as well. So many people who have that experience of suicidal distress aren't actually interacting with mental health services. They're interacting with other services such as education and justice and all of those sort of different environments. So it's getting the sort of right response for the right environment as well. So not answering your question directly, because it is a really tricky sort of outcome to actually say one solution for.
You're right. Yeah. And I think it is a very multivariate problem and a multivariate solution I can understand.
Yeah, and look, the family unit's so different now, isn't it? I mean, it's just critically different to what it was 10, 20 years ago. I know we mentioned about the difference in even having a conversation around mental health. Well, many things look different now. How houses look, how many people are mowing their artificial lawn? Not many. All of those experiences that you used to have social connection with are very, very different now compared to what they used to be. I'm not going to go near social media discussion.
You're right.
Yeah.
Probably, that's probably one of the segues we can go there. But I want to. You said one very interesting thing in the start about mental health nursing and as a curriculum, and you have observed. From a workforce point of view, young people are getting into workforce, and then either they are being an educators for young people, they're becoming teachers at some level. They're also doing, the Cert 3, Cert 4 to support as a care worker in particularly Australians and Australians with disabilities. And probably one thing which could be added there is the conversation on mental health, because everybody having that touch base with people of different age groups and demographics. So if mental health could be taught across the spectrum or that layer, so that it doesn't have to be a specific course or a curriculum. It is embedded in different curriculums as part of that's people will share things with you as you are providing them care, and then you don't know what to do, or you should get a bare minimum understanding of mental health challenges and how to initial diagnosis and identify an action plan, probably.
And we are doing some work with Community Skills WA and having exactly that conversation around no longer is the person just the person for in aged care, you know, and caring for this. They're actually talking to you, sharing with you, and that looks really different from a support worker, from a person who is potentially delivering your meal today. It looks really different because people are craving that interaction, but also really happy to share, look, I'm not travelling so well today. Because, I mean, that's really what's happened with our ability now to have a much more open conversation about mental health than we did before. You know, I'm not doing all right at the moment. Having the skills to actually respond to that doesn't come naturally to everyone. So, yeah, so it is exactly what you're saying about how we train our future workforce to be equipped in actually being comfortable with those conversations going forward. So
one is that skills gap, and second is the quantum of it.
Yeah.
So one is the gap of the quantum. So in your observation, what's the quantum gap in terms of the requirement of people with those skills of understanding mental health versus people out there?
Well, I think it's variable, like it is in every profession, group, etc. So, because I actually think you open a start of a conversation, you've got to have time to have that conversation, you've got to have the ability and comfort, and you've got to have the supports for you as well, if you're a person in that sort of situation, to kind of go, gosh, this I'm not wanting to feel like it's a burden, but sometimes it's feeling quite heavy for me as well. So supervision is absolutely an important component for people in a workforce environment. So we've got lots of people trained in mental health first aid now everywhere, and we haven't touched on family and domestic violence, but there is absolutely now a less stigma associated with things that used to be silent in the past. And I'm not sure we've fully equipped our workforce to actually manage that interaction all the time. So some people are super comfortable with it, others are not. So.
And many of the counsellors in many different sectors, again, different demographics, there's a new term which people start using, trauma-informed.
Yes.
And I just wanted to understand from your point of view how one can get an intimate understanding on, yes, trauma-informed. You can understand, somebody might go through a trauma from the past, but how do you, as an individual, empathize? Not you as somebody who's a counsellor who is interacting with the person. How can they better, just beyond education, how this trauma-informed act or practice looks in real?
I think trauma-informed is absolutely understanding what the person that you're interacting with is comfortable with. So, and you do that by having a good understanding of what your awareness is, how you actually manage your judgments as well. So we all judge very quickly when we interact, but ultimately being kind. Some of those really key skills of touch and light and interaction, and you're not going to know unless you ask someone around. We're going to have a conversation in this room here. Is that all right with you? So, and actually understanding around an opportunity for a person to say, no, it's not particularly all right with me. Is there another option? So sometimes actually giving people a couple of options can be more helpful for that individual to actually feel more comfortable to have an interaction with you. So trauma-informed is having an awareness, being, I guess, aware of your own judgments, but also not judging as well. So we know there's remains stigma around mental illness and also use of alcohol and other drugs. So if you've got an awareness of that and that's causing you some challenge, then it's going to be hard for you to interact with someone who that's what they're coming to you to have a conversation about as well. So,
can you talk more about your expanding portfolio on AOD as well, in terms of how does that work, and within the sector of very limited small sector of delivery of services within AOD space, what are the initial challenges you as a sector in the state?
So you mentioned workforce. Workforce is really a expanding environment at the moment. So, but the services around alcohol and other drugs are actually quite diverse as well. So we have withdrawal sort of services as well as residential rehabilitation services, but we also have phone services as well. So we have arrangements around diversion services for people who've are needing to actually having counselling for their use as well. So, but we have lots of peer-based services as well. So people who are able to work with people who are potentially using at this point in time, but also able to actually support them through what might be harm minimisation as well. So there's a massive sector out there that's actually quite silent really, but doing some absolutely amazing things for a really marginalised group. So because alcohol and other drugs really impacts on many people. Many people who are parents of children who have had a alcohol and other drug issue feel very stigmatised in being able to talk openly. So we have a phone line that actually assists parents in support to actually understand what they can do. And I guess give some hope that, it's a difficult time sometimes as well. So, again, giving people lots of options around what might not be a point of decision for them at this point in time, but what is, safe, how they can, potentially intervene with their friends and family if they're using as well. So so there's lots of things around as well. The variety of services are for younger people as well as people going into adulthood as well. So, but often you don't necessarily know what you need until you actually need it as well. So a very, very silent sector, but they're doing some amazing stuff as well. So.
What kind of challenges you see in the coming decade or so within the mental health space from a state point of view, and what are the key things you can see things coming on your table soon?
Oh, look, there's just some. I know you use the terminology of challenges, but we are, absolutely in a situation where openly talking about mental health is not as stigmatised as it was many years ago. So that's absolutely an opportunity. Us being able to marry with the demand of what people are seeking in different ways that they're actually seeking it as well. So. So the traditional, I'm going to go to a clinic and talk to someone and I'm going to tell them all about, what's happening for me, isn't necessarily a match for people going forward as well. So I think what we will see is quite a bit of innovation around how people seek and receive care as well. So as, we have our younger people coming through who are very happy to, use social media, or not social media, what do you call it? Look at me. electronic devices
the games,
to receive care, and how that's just really different to what it used to be as well. So,
probably you might have come through that. There are chatbots.
Chatbots, yes.
They're chatbots who are counselors, which are AI driven, and people are so that's the good use of technology, probably in some way or form, good and bad, I don't know, but there's no data right now because the initial and then people are testing that, but it's a bit of a rabbit hole. You go down that line of interacting with a chat bot or an AI tool or AI human.
I mean, some of the digitalisation is will be challenging, but also has those opportunities as well. I think for us as a commission, as long as we keep what is the variety of journeys for a person that can occur and ensure that services are along that pathway, and working with other services to actually deliver holistic care, that's absolutely got to be at our forefront as well. So I think the distance of Western Australia is going to be a continuing challenge, I think, as well. So, again, I think the communities will more and more tell us what they're expecting of services, and I think going forward we'll see a lot of marry of services coming together, like I mentioned, some of those hubs, and a bit more about wellness as well, so prevention going forward around people wanting to actually stay well, understand when they're not as well, and get early intervention as well. So,
Thank you.
Thank you.